Thanks, Mon. Thank you, everybody. So, as you said, my name is Subbiah. I work with Heart and Vascular over in Cartersville, out of the Piedmont Cartersville office, and we're going to talk here if help, my iWatch says I have Afib. I regret to inform all of you that I only get a paycheck from HVC. Nobody else has decided to give me any bonuses, so we'll look for that in the future. Just a very quick review. I know most of us know, hey, there's the normal heartbeat, which is sinus rhythm, and in Afib, you get these irregular impulses, usually coming from the atrial origin or from the pulmonary veins, that then activate the AV node, creating a narrow, complex, irregular heartbeat. And all of us know Afib puts you at higher risk for strokes, heart attacks, and thromboembolic events. So Afib facts, why does it matter? Well, a lot of people have Afib, right? The prevalence is very high, and most commonly the reason we care is all of these patients have worse outcomes. It's a 2 times increase in death, about a 1.5-fold increase in dementia and MI, obviously stroke, sudden cardiac death. Afib is the primary cause of stroke in about 1 in 7 patients who have a stroke. And I thought, one of the most telling things is when you get your older patients in the Medicare population, after a diagnosis of Afib, about 38 to 50% of them will be dead within 5 years. If you're looking for where we are, we're right in the sea of red right there. So we have some of the most highest hospitalizations for cardiac arrhythmias in the country. And symptoms of Afib, the most common presenting symptom is palpitations. Patients can also have chest pain, lightheadedness, fatigue, weakness. They can present with a stroke or shortness of breath. But very important for us, I think all of us realize, hey, about 15 to 30% of them present with no symptoms at all. And this is probably one of the most important slides, is what are our risk factors for Afib? Most of us know some of these: older age, high blood pressure, diabetes, vascular disease like coronary disease or peripheral disease, chronic kidney disease, thyroid disease, any episodes or a history of sepsis, obesity, sleep apnea, sedentary lifestyle, smoking or alcohol use, or even if you've had a history of cardiac surgery. And for the older ones in the room, like me, probably, I guess I'm getting older, we no longer use certain classifications. So things you might have learned in medical school or in training, like chronic AFib, lone AFib, valvular AFib, we don't call those that anymore. So as of 2023 with the ACC update, the new classes are at-risk AFib, where we treat risk factors, pre-AFib, where they're having frequent atrial ectopy or atrial tachycardia, paroxysmal AFib, when it's less than 7 days. Persistent AFib is now, it's greater than 7 days. Long-standing persistent is greater than 1 year. And permanent is actually, hey, we have made a shared decision with the patient that we are no longer going to consider any option other than letting them stay in AFib. And the reason for this change was that our electrophysiologists have gotten so good at doing ablations, even in longer standing AFib, that there are now treatment options for patients who have AFib. And the one that we're going to talk a lot about later is subclinical AFib, and this is what we're talking about, hey, incidentally detected AFib. Just happen to find it on some other sort of tests. And again, this is just sort of a brief summary from the ACC on a lot of those involve risk factor modification, and the treatment really starts once they get diagnosed with paroxysmal AFib. And the complications of Afib, I think all of us know this: hey, stroke, MI, thromboembolic events, worsening heart failure or pulmonary edema, and it can also increase the risk of VT, VF, ventricular fibrillation, ventricular tachycardia in the future. So the iWatch, it's essentially a one-lead EKG. It's not just Apple. Obviously, we all know there's a lot of other companies, Huawei, Samsung, Fitbit, and the KardioMobile devices. It's important to know that, hey, we are actually on newer devices. The first device was the Apple Series 4 that had this built into it. They are now on their 3rd generation of devices, which now have better optical sensors. And so essentially, when you put your finger on your iWatch, it completes a circuit between the crown of the watch, your heart, and then the receiver on the back of the watch, and that's how it's able to give you a one-lead EKG. It's important for us to know that, hey, most of the time it is not recording an EKG. So what it's actually doing is using photoplethysmography, and this is what, when you have an O2 saturation in the hospital, this is exactly how it works. There's an LED light and a photodetector somewhere, and the LED light goes into your finger, and then the photodetector is looking for the phasic changes of the arterial blood flow. And so when you look at different rhythms, so if you're looking at an EKG, well, this is what it looks like on a PPG sensor. So you can tell a normal heartbeat there at the top. AFib looks very irregular. SVT looks faster with not as deep highs and troughs. And even PVCs, you can see that. So this is what the watch uses essentially to try to figure out when you're having an event. It's not necessarily just an EKG. And it's important to realize, if you guys haven't been told this, a lot of people are wearing these devices. As of last year, about 50% of Americans have a device. 33 to 35% of them use it daily. And also since 2021, worldwide, just in 4 years, the amount of smartwatch users across the world has increased 2 to 3-fold. So this is a huge market for the guys making these devices. And on one hand, we know there's benefit to longer-term monitoring. If you look at that chart on the right, hey, the longer you have a monitor on, the more likely you are to catch any type of atrial arrhythmias or any type of arrhythmias. And multiple trials, including the Crystal AFib trial, which showed that an implantable loop monitor increased our ability to find AFib, and even the Find AFib trial, which said, hey, if you do a repeat monitor every 3 months, you're more likely to catch AFib. We know this data, hey, the longer you have a monitor on, the more likely you are to find it. The Apple Heart study was published in the New England Journal of Medicine. It was a joint venture between Stanford and Apple, where they looked at almost 250,000 patients, and they were monitored for about 120 days. And 0.5% of them, so not that many, had irregular heartbeats. They mailed those patients a 7-day monitor, and I think the next couple statements is key. After they got mailed a monitor, 7-day monitor, 35% of the patients who the watch said they had AFib was found on a 7-day monitor. Importantly though, of the patients who had a monitor on, when the watch said you had AFib, it was 84% right. So sometimes, getting back to the last point we talked about, 7 days might not have been enough. And it's based off this data that the FDA cleared the iWatch as the first consumer device capable of taking an EKG. So how good are these wearables at detecting EKG? Well, when you look at all of these studies, the Apple study, Huawei, Fitbit, they're detecting AFib in about 0.1% of normal, healthy individuals. Now, if you take older patients, age greater than 65, and you actually give them, some of these devices do record EKGs, then the detection rate goes up to about 1.5 to 4%. And the way the Apple Watch actually works is it uses the gyroscope to determine you're not exercising, and then if it sees tachycardia, that's how it's sending you the alert. And most recently on a meta-analysis in 2025, hey, these watches have gotten so good, they now have a sensitivity of about 94% for catching AFib. And if you look across there's multiple different types of devices. A watch is just one of them, but they make rings, there's patches, there's chest belts, and a lot of them have improved to around the 90 to 95% sensitivity for being able to pick up AFib. But what do we do with this? Hey, so there's this new term, something called subclinical AFib, and this is not the same as clinical AFib. So clinical AFib is we were looking for it, they came to us for symptoms or something, and so we did an EKG, we did a monitor, we found AFib. Incidental AFib is, hey, they were wearing a device, an iWatch, a pacemaker, no history of AFib, and we happened to find it. And the reason this matters is that the prognosis for the patients with subclinical AFib is much better than the prognosis of people who have what we would regularly call clinical AFib. And the duration really matters. If you have less than 6 minutes of AFib, you're not really at a higher risk of stroke or heart attack. If you have over 24 hours, well, then you are at a higher risk of stroke. And it's that, hey, if you only have less than a day, 6 minutes to 24 hours, well, it's not quite clear. And there's been 2 landmark trials in the last almost 1 year. The Artesia study, which was published in NEJM in 2023, where they looked at these 6 minutes to 24 hours patients. They randomized them to aspirin or Eliquis, and after 5 years or at 5-year follow-up, what they found was it did reduce the risk of stroke, as you can see, from 1.2% to 0.7%. but there was an increase in the risk of bleeding, 0.9 to 1.7. The other trial, NOAA AFNet, was actually stopped early because patients had higher rates of death and bleeding. And Silent AF, which is a trial which will be completed at the end of this year, compared again a DOAC versus placebo in these same patients. So what's critical here is in that top right, you can see, hey, if we take the same patients who have the same CHA2DS2-VASc score of at least 2, if they have clinical AFib, well, then their risk of a stroke was almost 4%. This is with the same risk factors. If they have subclinical AFib, their risk of stroke is only 1.7%. And that's compared to normal patients who have a 0.7% risk of stroke. And so you see that color-coded graph at the bottom there. It really matters how many risk factors they have and how much detection, how much AFib are we really seeing to try to pick out the high-risk patients who would actually benefit from anticoagulation compared to the low-risk patients. And you can see there on the right side, because what we end up seeing with subclinical AFib is we can reduce the risk of stroke in these patients by 32%, which is huge for some of them, because again, if you have a stroke there, that's a major functional impairment that you could get. But the cost is you increase the risk of bleeding 62 to 65%. And that's major bleeding, not minor bleeding. So what do we do when you send your patient to us? Well, we review the EKG tracings from their wearable devices, and we provide an overread, because a lot of times the device is not correct. A lot of our patients still today, I think most cardiologists still order a monitor, either a loop monitor, a 30-day monitor, 7-day monitor, some other monitor, try to confirm the diagnosis. We usually check an echocardiogram to see if they have any structural abnormalities, and then we usually assess their risk of bleeding, risk for anticoagulation. Hey, what is the risk that they're going to bleed? We monitor all those risk factors we talked about at the beginning, and if we feel the risk versus the benefit analysis says this person would benefit more, then we are starting medications in anticoagulation. So some key conclusions I want to get to is, if you don't have AFib, does everyone need an eye watch to try to figure out they have AFib? And I would argue probably not. In one study published, it said, hey, listen, the prevalence of undiagnosed AFib, true AFib, is about 1.3% in age greater than 65, but 0.1, which is about what all those iWatch studies showed in the younger population. And on an event monitor, if you ask any of your cardiology friends in the room, we can tell you when we get young patients with event monitors, there's almost 90% of the time when the event monitor has a notification, it's a false notification. So it can be very helpful in certain patients who are older, and especially if they have those risk factors or symptoms. In a healthy population, I'm not so sure it's that beneficial. But knowing you have AFib, I think that if you take one thing away, it's knowing you have AFib isn't the full picture. You really need to know how often, how frequent, what are the risk factors, what are the symptoms, is this subclinical or clinical, and what's the risk-benefit analysis for putting someone on anticoagulation. And whenever you give a patient too much information, there's always things that go with that too. So when patients can see on their iWatch that they're having AFib or PVCs or bradycardia going down to a heart rate of 50 or 40 when they sleep, these are things that most of us have seen in the hospital, and we just write off as that's nothing, that's normal. But obviously for an untrained medical professional, a normal patient, that could be very concerning. And in a lot of patients, it can worsen their anxiety. And it's also important to tell them what the watch can't do, at least not today. It can't detect an MI, it can't detect a stroke or a PE, it can't tell you your blood pressure, and it can't tell you if you're having other arrhythmias or heart failure. I think some really cool things are coming down the pipe though. They are doing multiple studies looking at if a multi-channel EKG can detect a STEMI. And this study out of 2020 said that there was a 93% sensitivity if you had a multi-channel EKG to detect a STEMI. They're getting better at identifying re-entry SVTs, and now some places are actually using them for QT monitoring and QT prolongation. And I think, there's a trial coming out that's called the REACT-AF trial. It won't be completed until 2029. But it's a very interesting take on AFib. It's people who have non-permanent, so paroxysmal AFib, And it's instead of what we do today, which you get anticoagulation forever, it is you wear a smartwatch and you only get anticoagulation if your smartwatch detects AFib for 1 month. And after that month, you go back to having no anticoagulation. And it'll be very curious to see what the bleeding outcomes and all that are for those trials. So that's it. Any questions?